Welcome to the Contemporary Policy Institute, informing the public debate on the policy challenges facing the U.S. and the world. Please welcome our founder and president, Andy Thorburn.
Good morning and welcome. Welcome to the Contemporary Policy Institute. This is one of four in our series of policy learning series. Let me tell you a little bit about our panelists and our guests today before we get started. I want to first, though, tell you a little bit about the Contemporary Policy Institute. I want you to know a little bit about us. Probably most of you haven't heard too much about us. So let me tell you, first of all, about Contemporary Policy Institute. We're going to have some slides. They're very simple. These only take about 30 seconds to give you a brief introduction. First of all, we are a 501c3, a nonprofit public policy institute. And our goal is to try to have an effect on the public debate in the country on the various challenges and pressing issues facing the United States, domestically and internationally. And the tools that we want to use to emphasize aspects of this public debate, to impact the public debate, are first of all, we want to emphasize critical thinking. Second of all, we want to emphasize the use of data. This is one of our goals, is to try to provide a background of data to inform a public debate. We want the approach to be educational in nature and not advocacy. And we also want to take all of these elements to try to provide a firm foundation, because we want the public debate to revolve around solutions to problems. We want to try to make sure that there is sometimes a common understanding of the factual background, so that then we can debate solutions and approaches to the problems that we face. And so today's topic, as I said, in this policy learning series, which we're doing jointly with the Bench Product, is building healthy communities. First of all, our panelists will join me in a discussion is Shana Charles. Shana is an associate professor at the Department of Public Health at Cal State Fullerton. Thanks so much for joining us today, Shana.
Thank you for having me. This is a great opportunity to educate the public on this topic, and I'm really excited to be here.
Good. Let me introduce you to the panelists who will be joining us as well. First of all, we're very pleased to have with us Senator Josh Newman. Josh represents Senate District 29. Josh is also a U.S. Army veteran. But most importantly for today's topic, Josh is the chair of the Special Committee on Pandemic Emergency Response. So thanks so much, Senator Newman, for joining us today.
Thank you.
We also have Mac Giliiland. Mac is a community activist and retired educator. And before we go any further, I think it's appropriate to say happy birthday to Mac. I think today is your birthday. Is that right, Mac? Is it today or yesterday?
Mac's muted.
Well, happy birthday and thanks for joining us. We also have Olivia Guevara, a political and community affairs representative at the United Nurses, the Union of Healthcare Professionals. This is really critical to today's topic. They represent 32,000 healthcare workers, and we're really looking forward to having some input as to what you've encountered during the COVID crisis and generally in terms of building healthy communities. And also we have Linda Fina, also a case management nurse and community activist. So we will have an opportunity to get some feedback from people directly involved in building healthy communities and directly involved in healthcare issues. So those are the people that will join us. The format is pretty simple. There's a discussion guide we'll put up on the screen so you can take a quick look at it. We're not going to follow this discussion guide exactly. There are a lot of topics will overlap with each other, so we'll probably jump around just a little bit, but this will provide a kind of organizing principle for us. And what we're going to do is really Shane and I will have a discussion about these topics. And as we transition, Shana, from one topic to another, we'll call on some of the panelists, to give their perspective on that topic.
Okay,
For example,
sounds great.
We're going to start with the very general idea of what does it mean to build healthy communities? What are the needs? What are the things you look at? What are the metrics that you use? So we'd like to have your comments. And when you're done, before we go on to the next topic, we'd ask Senator Newman to provide his ideas on this idea of healthy communities.
Okay, great. So the idea of public health is something that's new to many people, although last year they got more of a taste of it, certainly as we all went through this pandemic together. But public health is different from medicine and healthcare. In medicine and healthcare, You create a hospital, a doctor's office, and you wait for patients to come in with problems and you diagnose them individually. That's a medical model. A public health model, which by the way, many hospitals are doing now. I don't want to say hospitals aren't doing public health because they really are. But the public health idea is that we know things that are good for everybody as human beings to help build up physical and mental and emotional health. And so we want to proactively bring that to people in a widespread population way to get as many people as possible in your community to be as healthy as possible. So it's really a promotion and prevention mindset as opposed to a diagnosis and treatment mindset. Now, you definitely have to have healthcare to improve the public's health. I mean, you can't, that's part of what we look at when we look at a healthy community is, do they have access to doctors and hospitals and clinics? All of those things are vital, no question.
So we could say, though, that the idea of public health is to be more proactive. Don't wait for the sickness to come. Try to do a little bit of...
Exactly. And we can also talk about things called upstream factors in this framework called the social determinants of health, which is becoming a more popular, widely used phrase, so people might have heard it before. But the idea of upstream is that you want to help people with things like housing, education, transportation, the environment in which they live, employment, because all of those things on the upstream level contribute to people's mental and physical and emotional health and will help them be healthier if they have good housing, free public education that's high quality, employment opportunities that are nearby, an environment that's clean for them to live in, all of those opportunities as well.
So then I would add to your definition, so to speak, of public health. It's not only proactive, it's much more comprehensive than going to the doctor and saying, my arm hurts.
Absolutely. And there's this idea also in the government side that the government as the protector of the public in general. And some people think of that only as a fiduciary protector, right? That they're protectors of the public money. And in some sense, that's true. You want to make sure that you spend your money on things that are good. Well, what defines good? There's this idea of health in all policies that is really key to local governments these days that, and there's even a document on this that people can go find. If you just search health in all policies, it pops right up and it's free for everybody to look at online, that promotes this idea of if local governments invest in things like parks and things like clean air in their environments, and also things like neighborhood centers where people can go for classes or after school care and all of these things, that's all part of public health and promoting the public's health.
Well,
it's
Josh,
very wide reaching.
Josh, before we ask you to give your perspective on it, you might get to be the one to define what we mean by good. I do want to make a comment that you just triggered about parks. So Karen and I noticed during the pandemic, we go to some local parks, and we do have a terrific park system in Orange County. But they always seem to us to be underutilized. I went to this magnificent park. We have Irvine Regional Park. Near our house, we have the Santiago Oaks that I introduced Michael to. It's a beautiful sort of wilderness park. Mm-hmm. But all of a sudden, during the pandemic, they were mobbed. And I'm hoping that people will have, from that experience, a greater appreciation of the resources that we do have that really were completely underutilized, in my opinion, in the past. So maybe there'll be some good from that.
Get people out of their cars and into the parks.
Yeah, I appreciate it. So, Senator Newman, though, so you heard a little bit of introduction from Shana. What's your perspective on this healthy communities?
So I truly appreciate Shana's perspective. And before I start, thank you for having me. That lens of looking at the public welfare through the social determinants of health is important, right? It's particularly from my point of view. So my job as a member of the legislature is to ensure that we as a state have the policies and especially the resources to fund all of those determinants that Shana mentioned. And I think it's important to note, I mean, on the one hand, you mentioned, parks have been busy during the pandemic. That's good. And it's not just cars, it's getting people out from behind their televisions. But it's also been very clear that we have underinvested in a whole range of sectors that left certain groups much more vulnerable to the pandemic than others. And so, that is proof positive of exactly what Shana is talking about.
Right. I appreciate that. And I think that's important from a public policy perspective, because after all, our goal here is to understand these issues from a public policy perspective. That's our whole goal. So that would lead us naturally to ask, if that's the goal, public health as you described it, how do we do a needs assessment, like locally in each little community? I'm on the maybe I'm a city council member.
Right.
What do I do in a needs assessment?
That is tough, honestly, because it takes funding and state funding, maybe, or possibly national funding. I just put in a grant proposal myself to the National Institutes of Health to do basically this kind of needs assessment work with Cal State Fullerton students who make up a 40,000 person population within Fullerton. So yeah, it's the needs assessment side, I think is at this point underinvested at the government level. There are some places where you can get that data on a local level. The Orange County Healthcare Agency has a good clearinghouse called OC Healthier Together that brings together a lot of data. And then there's also a survey that I've done a lot of work with over the past 20 years called the California Health Interview Survey that provides really great data on the county level, and it's all for free. Los Angeles and San Diego counties have some sub-county ideas and also more local areas if they can pay for the data, which isn't too expensive, maybe $1,000, they can ask for data for their own city. But that is a project of the UCLA Center for Health Policy Research, the Public Health Institute, which is in Central California, and also the California legislature, which has funded that for the past 20 years because of how important it is to the state of California to have good data.
So there are some resources out there.
There are. The problem is that so often the people like me who know about the data don't have direct connection to people on the city council, to legislators. That's something I myself have tried to change. I'm pretty proud of the fact that living in Fullerton, I personally know every single one of my representatives, that I've met them in the past and have possibly worked with them. And, you know, we consider ourselves to be a resource for data on the academic side, but in some sense, you know, we're overwhelmed with teaching and all those other things. And so it's sometimes hard for us to carve out the time to do it. And when you think about the needs assessment for Orange County, and you think about all the different cities in Orange County, so many of them, you know, just don't have the time and the resources. Placentia, for example, is 20,000 residents. Right. They don't have city funding to be able to look at just their city, right?
No, I think it's good to know that there are some resources out there. And I do think you made a good point. We have to take it as a project to try to educate candidates and office holders to understand that there's a lot more out there than they might think that will help guide them in making decisions going forward in public health issues.
Yeah, and think of public health departments, you know, the Orange County Healthcare Agency, but then also academic public health departments as resources. UC Irvine and Cal State Fullerton both have great programs and faculty members that are interested in a wide variety of things. And our discipline of public health, by its very nature, wants to work with the public and wants to help out with these things. So a lot of us are very open to someone calling us up and saying, hey, can you work on this?
And one small aspect, trying to go back to the agenda for a second, of building healthy communities and local issues is there are some state mandates and some state programs. Mm-hmm. So one of the state programs is the California Healthy Youth Act. We're not going to really spend time on it because we actually did cover it in an educational segment that we did. We spent quite a bit of time on it. But I think it's worth noting here that as you do a local needs assessment, one of the things you have to look at is how well are we doing in taking these state mandates and making them real.
Yeah, the evaluation side on the back end, right? So once you pass something, did it actually work as it was intended to do? And even if it was implemented the way you wanted it to be, did that have the effect that you wanted? Those are open questions.
And we know that in this case, the Healthy Child Act, there is a lot of pushback and it hasn't been implemented in each district. So if you're a public official, one of the things you want to look at is, okay, we have this state mandate. It's a well thought out mandate. It's not perfect by any means. None of them are. It's a political process after all, but you want to look at how are we doing in this state mandate.
Yeah, and I do think it's also important that the name of it was the Healthy Youth Act, even though it was directed at public education to educate people about, you know, all genders and include that as part of comprehensive sexual education. I think the point of it is that it does help students' mental health. That has been shown by research study after research study that if you discuss these issues, what you're doing is suicide prevention. You're doing depression prevention. So it, you know, the idea that health is in that aspect of education, you know, is part of that social determinants.
It's not a sex education act, it's a healthy youth act.
Exactly.
So let's transition. We talked about public health. We all know that we're in a pandemic. We think it's winding down. We hope we're in the final stages, but that might be wishful thinking.
Numbers are wonderful, though.
The numbers look very
really
good,
are.
particularly in Orange County. They're really declining rapidly. But so let's ask maybe if Olivia can give us some input before we go too deep into this. Olivia, you probably have a lot of feedback from your members. And maybe you could tell us what you think are some of the things you've learned about what we don't have and what we do have, what your experiences have been from the COVID pandemic.
Absolutely. Again, good morning, everyone. Thank you again for having me here. I'm with United Nurses Associations of California, Union of Healthcare Professionals, and most definitely, I know we're going to later talk about this some more, but really what has popped up has been the access to mental health resources, not just for our healthcare professionals, but our communities as well. I think we definitely put ourselves in a situation that none of us expected that we were going to go through. I don't think any of us ever thought that we would be going through a pandemic in our lifetime, at least, but here we are. Now that we're here, what are we offering, our healthcare professionals? What are we offering our communities, right, who are struggling? And even then, I think one thing you all said earlier is that each community looks very different, right? For example, what about communities who are just, speaking a different language, right? We have so much information nowadays in just English, but do we have access to be able to translate those documents to the other languages, right, that are present in these communities? So definitely those access issues. Also the push, I know you talked about this earlier, the push about proactive care, right? Let's not go in when we're hurting. Let's go in now so that we can take care of ourselves and take care of our bodies. Because I think that's where a lot of our hospitals, and then maybe Linda, you want to chime in on this, where we got very bombarded because people were coming in and we just did not have the manpower and or supplies to be able to take a huge influx of patients coming in because of this pandemic. So yes, definitely more resources, especially for healthcare, mental care issues.
Well, going back to a fundamental point that you've been talking about and which Shana mentioned earlier, I think the biggest takeaway from COVID that we want to make sure we reemphasize is, and I think Shana made this point, it demonstrated beyond any doubt the need for public health resources. You can go many years and not see a dramatic incident. Of course, we have a homeless problem, which is related to public health. But when you talk about direct impact on the entire population, you have a pandemic which cries out to say you cannot defeat this pandemic unless there's a concerted public health effort.
Right. And I think, going back to what she was saying about mental health services, that was part of the pandemic that even if you didn't get sick, would affect you, right? So that really affected, I think, 100%. There's really no one who can say, well, I was trapped in my house under a stay-at-home order, and everything that I usually do on a daily basis was closed, but it doesn't affect me at all. Exactly. That they would be just delusional in some sense. So I certainly the need for mental health services skyrocketed. One thing that I do want to point out was the nimble transition to telehealth that was really incredible. I think the providers, moved mountains to make telehealth possible and also compliant with all the privacy regulations. People have heard the word HIPAA, and those regulations. I mean, props to them and to all the nurses certainly who found themselves working in dire and desperate circumstances. I have to say, from the bottom of all of our hearts, thank you for all your work. But that point about translation services, that brings up such a great point. And in California, we have some of the best translation services and some of the most professional, the strongest, most robust translation services in the country. And yet we still fall, very short in this. That's certainly an area that if somebody has a talent and a skill, please go into it. Because we have, there's so many languages in this state. I believe the actual count of things that they translate into is into the 40s. They have to do. And then you have, your top 10 languages alone, right?
I'll give you a small anecdote because I was in this business. When you send out a claim form in California, you actually have to include 13 languages just in the claim form. So
right, and
those are the 13 main languages.
And that's a very robust regulation, right? Most states don't even have that.
They might have 2 or 3. Usually Spanish might be required, maybe maybe in another state, there's a lot of German speakers, but in California, it's 13 languages.
Yeah.
I know that because it was quite a burden for us to do it, but obviously we complied, and it helps bring in some of these marginalized communities.
And in California, we have many populations that are the largest population in the world outside of the native country, you know, especially in Los Angeles and Orange and San Diego counties, which are, and also Riverside and the Inland Empire. I mean, people forget how concentrated the population of Southern California is for the whole state. California itself is the size of Canada in terms of population, and over half of that is in Southern California. So the incredible multiculturalism and diversity here is wonderful, but it also does make healthcare services more difficult.
And it's one thing COVID obviously highlighted, that it's much harder to provide these public health resources when you have to deal with a diverse population, but you have to be aware of it and deal with it from a public policy point of view. And I want to go back from the point of view of public policy specifically, to talk just for a second about telehealth. And when you're done, I'd like to get Senator Newman's take on this as well, because to do telehealth after the pandemic, it does require some change in statutes. It has to be permitted by various regulatory agencies. So I wanted to get your take on whether you think, Shana, as well as from Josh, whether you think telehealth will remain a big part, or you think it's going to fade back as the pandemic fades?
I don't think it's going to fade back. And I'm basing this on work that my colleagues have done. This is not a topic that I myself have researched, but I know in the California legislature this spring, there were bills on telehealth to expand those emergency authorizations permanently. And of course, we don't know what is going to happen with those bills, but the research that was done on that, showed that it is something that helps patients, saves money. It's kind of a win-win for everybody. I mean, and I really think that they're going to want to keep people out of the physical offices as much as possible, especially as looking forward, we're not sure whether or not variants are going to pop up or if there's going to be another surge, those kind of things.
For various reasons, the medical establishment has fought it for a long time. Maybe they're softening up a little bit, but Senator Newman, what has been your experience in Sacramento on this issue of telehealth?
You have to unmute.
Yeah, we can't. Josh, if you can unmute yourself.
As I was so eloquently saying before I unmuted myself. So as Shana mentioned, there are some interesting positive effects of the pandemic, and one of those is the now ubiquitous use of Zoom and other modes of communication. And so telehealth, both by way of telephones and by using Zoom and things like this, has been immensely useful. Not only to keep people out of harm's way, but to reach people who otherwise might not otherwise get care. In Sacramento, as a legislative matter, we have a couple of questions that we need to solve. To your point, one is what are the regulations around telehealth, particularly around privacy? But more importantly, in California's very complicated healthcare system, we have to figure out the value of a telehealth visit relative to other things. And what we don't want to do is, because of payment sort of imbalances, create disincentives for not only patients, but more importantly for physicians and for healthcare organizations to use this powerful new technology. So that's one of the things, as Shana mentioned, that we're working through in Sacramento, because we have to figure out where this fits into the continuum of care, so that we make best use of this technology.
I hope, as you both hope, we all hope that it's here to stay, because it is a great tool. And I've done a couple of appointments on Zoom, and it's convenient and it's quick, and it's doctors get to see a lot more people during the day. So let's hope it does stay.
I will say, I don't know if in your experience it was actually on Zoom, but I feel like we're using Zoom almost as we use the word Kleenex these days, that it's become so ubiquitous.
True. Mine was Zoom, but you're absolutely right.
But so that must have been a private provider. But like Kaiser, for example, set up their own internal video system that they send out private links to. So that's how they were able to do it. And I'm sure when it comes to Zoom, that your provider put in all those extra protections so people couldn't do the thing called Zoom bombing, right? And get into it, because you really do have to care about those privacy issues and some of those technology issues. Yeah.
And if I could add one more thing, and it's related, and it's about broadband access, right? And so one of the most important things we can do as a state is ensure that everybody has the same access to technology, particularly to bandwidth, to broadband, so that they're not otherwise squeezed out of the use of these technologies. And I know that Olivia can speak to this as well.
Well, that's a good point, Josh, and it actually ties in with the whole idea of lessons from COVID. One of the lessons would be that broadband access is not just a convenience. From the point of view of public health, it's a necessity. The world we live in today, we can't look at broadband access. You remember the stories, if you go back 20 or 30 years, it would be a big outcry if somebody who was on unemployment compensation had a color television. That's a luxury that we shouldn't pay for that. And now it's broadband. It's not a luxury. It's something that everybody has to have access to. But moving ahead though, just because I think we've alluded to some of these points, we did mention that one of the lessons of COVID is the need to always address the marginalized populations. One of the things that we recognized early on was if we didn't pay some attention to the homeless, for example, we really could not defeat the pandemic because there's an exposed population, they're marginalized, they don't have access to health care. And no matter what we do with the general population, the homeless could serve as a reservoir for the virus to continue to have a place to thrive. And so we had to do something. And if you remember the early months of the pandemic, nobody wanted to provide much resources. We even had a struggle in Orange County getting permission to give hand washing stations in homeless encampments. There was resistance to even that amenity. Even though from a public health point of view, that was good for the whole population as well as the homeless.
Right.
So one of the things we learned was the need to involve the marginalized populations, and you mentioned language as another example. But I want to get Mac involved here for a second.
Oh, I was going to say,
ahead,
I just
sure.
wanted to mention
Sure.
just one thing there. And part of it is that became forefront in the public eye in 2020. But, in 2019, we were having measles outbreaks and we were having hepatitis A outbreaks among the homeless in San Diego. I mean, and so, public health professionals, people who work at these healthcare agencies, they were already focused on these basic measures as part of prevention for other diseases. And then COVID just made it much more urgent.
Made it more urgent. And
brought to the forefront.
hopefully we'll stay in the forefront.
Yeah.
That we have to include them in our plans. But that brings me to a point that Mac, as a retired educator, maybe you could give us your perspective on the fact. One of the things we have to do is overcome misinformation. All of these things, whether it's the Healthy Child Act or the COVID vaccine, there's all kinds of misinformation out there that makes it difficult to enact some of the public health measures we'd like to enact. So, Mac, I don't know if you have any ideas or perspectives on the effect of misinformation and what you think we could do to try to overcome it.
Well, I really don't. I think I'm as perplexed as anybody by the ease with which a lie travels around the world at twice the speed before the truth can get on its shoes. That's an old cliche. But I really been retired from education for about 20 years. All I can say is I access the facilities for COVID shots and COVID testing, and I was extremely impressed with its efficiency and its service. However, as a senior citizen who doesn't live without a teenager, accessing the computer skills to do all of that was a little challenging. But all of us have to keep our learning curve fresh. So I really can't contribute much there. I'm sorry.
That's okay, but you did make a good point that I think as a public policy, not only do we need public health access, we need teenager access. That has to be one of our, everyone needs.
I would grab one who passed by and say, can you come in and help me? And they were most accommodating. Yes, thank you.
But the misinformation problem, has been with us for a long time. The COVID has made it worse. Obviously, social media has made it easier to spread it, as Mac alluded to. But it's a real problem. What's your perspective on that, Shana?
So this is interesting because I actually have been studying health communication for many years. And this is something that the idea of trusted communicators is so important. When people decide who to place their trust in when it comes to health, usually it's their own doctor. But it can also be, community figures. It can be a community clinic center. So for example, in Fullerton, we have this Center for Healthy Neighborhoods in one of the lower income areas of Fullerton. That's a collaboration of our department with the city, and they've become trusted advisors. And so people turn to the people they trust for information at that time. Now, the problem with COVID specifically, and part of the problem we have writ large right now, is that there is a large population of people who are trusted advisors. And in 2020, it was the president, it was, the Secretary of Health and Human Services. They were the ones providing misinformation. And it was really upsetting to see that. And that they were suppressing the CDC. That's been documented now in 2021 here, when the CDC has now been allowed to show what happened in 2020 to them, where they had their data suppressed and their announcements suppressed. And if you recall, there was a scientist from Health and Human Services who in February of 2020 was trying to get out the right information, and she was silenced and moved to another position. So when you have that kind of mismanagement at the government level, and here in Orange County, we saw a little bit of it with the County Board of Supervisors, where there was a real split, and someone like Andrew Doe and Doug Chafee, they were trying to get out the right information, and then they were being fought by two other supervisors who were putting out misinformation, and it was really difficult.
Let me back up for 1 second. Olivia, I know you have these thousands of members, and they're exposed to all of the misinformation. They hear about it from their clients and in the community. But I wonder if you could just share with us if you have any experience where your members themselves maybe had some misinformation, or maybe had to deal with it in their daily responsibilities. Yeah, I think you're on.
You're on mute, Olivia.
You have to unmute yourself. Thank you.
Okay, thank you. For the most part, a lot of our members were briefed daily because, as you all know, in healthcare, things were changing every hour. So they were briefed daily every time before shift. I think for them was more so the information that the community was coming in terms of, hey, I don't need to wear a mask anymore because I've been vaccinated, or I don't need to wash my hands, or all of these things. And I think it just got to a point where a lot of our healthcare professionals just stopped folks immediately in their tracks and said, no, this is what you need to do. So yeah, it wasn't so much from them, but it was what the population was bringing in, right? And then how do you then change that mindset, that rhetoric, so that they don't go back into the community and misspread that information? So definitely, we felt that we were at the front line in terms of being able to deliver correct communication about what to do, what to expect, what not to do.
That's exactly the kind of input I appreciate you sharing with us, because it ties into Shana's point that your nurses, to a large extent, are trusted sources, because it isn't helpful for somebody else to kind of confront misinformation on, you're in a conversation with some acquaintances or in a restaurant, and confronting that person about masks or misinformation isn't helpful, because to them, I'm not a trusted source.
Yeah.
But when we do have trusted sources, like nurses in the community and other people that have some credibility, obviously it's very helpful to try to stop it at the beginning and say, look, that's not right. Let me try to tell you what the facts are.
Yeah, I would love to see going forward a stronger commitment to truth and honesty among people who are those trusted sources, and recognizing that they have a responsibility, because the words that they say really matter, and people's lives are affected by them. When you have somebody in government, in your local government, who says, I don't care about masks and it doesn't matter, and this is, in the height of the pandemic, and we're just going to forget about it, then there's going to be a population that's going to follow them, who voted for them and thinks that they're right. And then it affects everybody else, regardless of whether they want to or not. So yeah, it's just important, I think, for people to understand that if you are a health communicator, someone in a trusted position, you really need to adhere to facts, adhere to the best scientific data at that point. And sometimes that scientific data won't.
And I think that ties in though perfectly with the whole point of these sessions. We're trying to say, from a public policy perspective, your goal has to be to have a commitment to good, solid data. That has to be your commitment. And if you're not the one responsible for the data, then you have to make sure that your colleagues are also held to that high standard. So from a public policy perspective, battling misinformation is critical. But we're going to talk a little bit about mental health resources in more detail. We've talked about it quite a bit, peripherally, as it impacts all the other things we've spoken about. And while you give it some thought, we also have Linda with us, who is a case management nurse and also a community activist. And Linda, maybe you could share your perspective on mental health resources. What's out there? How do you access it? Do you think we need more of it? I doubt if it's adequate, but I'd like to hear what you think. What's your thoughts on mental health resources?
I kind of want to share with the population that I work with right now is all Cal Optima with a medical group. So I look at their health risk assessments, which are have a lot of social determinants on it. There's a lot of issues with health literacy and health education. knowledge through CalOptima, which is what I'm most familiar with. There are referrals to some providers in the community, but it also that they're I believe contracted with. But for the average person, even as a Kaiser enrollee here, it is very difficult to access mental health. There's a lot of hoops and a lot of barriers, I think, to getting on mental health. I have one other comment for you, Shana, is that there is a real trend called care at home, where a lot of services are provided at home. So people can get their care at home with whole teams coming out, and CalOptima does do that, and as do some other health providers.
Linda, you mentioned obstacles to getting into the mental health care system. Do you have any suggestions of how we could help reduce those obstacles, overcome them a little bit?
Well, there's so many. I think having a part of the health plan or your insurance is easy access to self-referral would be one. Maybe self-assessments for depression, anxiety, loneliness, suicide. All these things could be self-assessment. Just there's so many barriers. Even at Kaiser, you have to go through all these people you got to talk to, this, that. I've looked at it, and there's just a lot of hoops to get there, and they provide pretty comprehensive services. Probably one of the best in the area.
Yeah, I'm trying to remember if this is correct, so someone might have to correct me. But as I recall, Obamacare did make the change that mental health care is treated as any other illness.
Oh, you are talking my language.
Yeah,
Okay.
there's no limit as there used to be in old policies. Is that
right?
correct?
So this is something I've been looking at for quite some time. So before the Affordable Care Act,
Right.
also known as Obamacare, you also had the Wellstone Act,
Right.
which was the Mental Health Parity Act. So officially, even before the ACA, mental health was supposed to have parity, but it wasn't implemented very well, and it was the insurance companies really fought it even after it was enacted. So yes, the Affordable Care Act did fix that. It's a real triumph from the last 20 years that we do have parity now, where mental health services are at least covered by all insurance. That was a first
if you get
step.
through the system and get the coverage.
Well, that's the problem, is that
right?
you have this issue of being underinsured, which is something I've been concerned about for about a decade now, where you have people with coverage, like Linda is saying, but then the access isn't actually there. And it could be because barriers are put up administratively, where you have to see multiple people to even get a referral, or it could be that they just don't have providers available. So they'll say, and this happens quite a bit with Kaiser, they've been fined many times by the state for this, where they say, okay, we know you need services, we agree, you have this diagnosis, we'll see you in a month from now, which in a mental health situation is very too long.
Linda, did you want to add something there?
No, I was going to say exactly that. They have had multiple lawsuits you can get a mental health appointment in 6 months. It really is not very helpful. Through CalOptima, there are providers that it's not that difficult to get appointments for people within this program. It's also them, the education, you can lead the horse to water, but you can't make them drink. And that's with health literacy and health education, I think.
Yeah. And again, I would love to encourage anybody listening who's interested, if you have any urge to be a mental health professional, that is a place where you will have job security, because they are needed. We absolutely have a shortage of people that are willing to be therapists, psychologists, psychiatrists, all the way through. It's certainly going back to that idea of translation, people who are multilingual in mental health services are so few and far between that if you have any desire to go into that, please do, because we certainly need you.
So is there any state program that either exists or we could push that would give more incentives to have more mental health professionals, make it an easier path, a career path?
I'm not aware of any in terms of beyond just your normal scholarship programs. We don't have that many professional programs in terms of schools. So that would be another issue in terms of specialties. They're usually in schools that are outside kind of the main public systems of CSUs and those kind of things.
And most of the mental health jobs, counselors and psychologists, psychiatrists, and social workers, most of them require advanced degrees. It's not just a bachelor's degree. Normally you have to go on and get a master's degree. I will say though, some of the obstacles are bureaucratic, obviously. I notice from a family point of view, because my daughter's a licensed clinical social worker, and this is what she does for a living, but she lives in New Jersey.
Yeah.
And California will not accept her credentials from New Jersey. She has to go through a whole process rather than just picking up the credentials and saying you can be in practice. So it's going to set her back. And that means that there'll be clients that could get service that won't be able to get service. So there are some, we have the senator, of course, still with us. So there are some things we can do legislatively and bureaucratically. And again, we want to always focus on public policy. So we're looking, what can we do from a public policy point of view, Josh, to get more mental health resources available to people?
So it's a good question, and obviously a pressing need, Andy. And so California is a fairly innovative state, and so we passed by initiative several years ago something called the Mental Health Services Act, which taxes high income earners, and that money goes directly to mental health services. But the act is probably in need of reform. I'm sure Shana can speak to it as well. And so that's, to my mind, what we should be doing right now, because your point is well taken. And Shana's as well. I mean, most of the people in need of mental health services are not high income individuals, right? So the only way they're going to get it is through the public health system. And the only way we're going to do it well in California is if we allocate those resources and design programs that reach all of the different communities in need of these services. And so not only is it important for the practitioners in these spaces to speak multiple languages, it's really important for us as public servants, for the government, to make sure that these programs reach into those communities where typically English is not spoken, but where mental health is clearly a very important need.
I do want to bring up an innovative program that started here in Orange County near the end of 2020. That was started by Dr. Margaret Bredhoff, who is our new public health director in that department. And she started in the middle of 2020 as well. So in the middle of all that, she decided this is what I want to do, which hopefully that spirit will imbue more people. But she started a program specifically for elderly homebound people who were experiencing higher levels of depression in the pandemic because now, being homebound and then losing a lot of their services. So going back to what Linda was saying about care at home, they created this program where somebody would come to that person's house, knowing that they wouldn't be able to do a telehealth appointment. They weren't, savvy enough technologically, or maybe didn't even have the broadband access, but actually go and visit the home for a mental health visit among the elderly who were in that program. And that was through the Orange County Healthcare Agency. Right. I mean, that kind of innovative thinking is what we can do more of, but it's hard when you do, small population by small population.
It is, but it does point out that we have to make sure, again, for anyone in a community activist or anybody that holds a public office, they really need to know there is I would say just from this conversation, a kind of bewildering array of resources. It's not all in one place. You have to really have a lot of knowledge where to go to get a particular resource and how to get through that process. So if you're a public official, that's a daunting task.
And it is. It's a daunting task for everybody, even people who have PhDs in these things. It's hard to go through this system sometimes. And so part of what needs to happen is more streamlining, more public education. And you get things like the billboards for, covered California, right? That you can sign up for health insurance there. But then where do you sign up for these other programs maybe you don't know about, So it's interesting because that's part of what I'm trying to actually work on with the Cal State Fullerton, thinking of that as my community, and that the students there, who are young adults, and a lot of them, being on their own for the first time, don't know how to access so many of the resources that exist for them. The food pantry on campus, the basic needs center that can help with housing, things like Covered California to help with health insurance if they're uninsured because they weren't on their parents' coverage because their parents don't have private coverage. All of those things, we're trying to create a program that's going to streamline that for them and be able to link them in because in so many cases, the programs and services exist and people don't know how to access them.
Right. So we might come back to this just when we summarize at the end of the session, but it seems like for mental health in particularly, we could say that, first of all, there are a lot of decentralized resources, and maybe it's too decentralized to some extent. So we have to do an educational job so that public officials, as well as the public that needs the resources, knows it's out there. There's also obviously a problem of bureaucracy and access to these resources that we have to address in some way. Some of them, I'm sure, deliberately set up by insurance companies to limit their cost. Some of them just the result of bureaucracy in general. And so there does seem to, so therefore it's very hard to get a handle on, do we have enough resources or not, because it's hard to get a handle on such a spread out resource base. So we do have some challenges in mental health that we can maybe come back to, and
Yeah.
it seems like the direction is pretty clear what we need to
Well,
do.
yeah, certainly. I mean, when we do large population assessments using mostly the California Health Interview Survey, where they have questions like, have you delayed mental health care that you needed? Have you delayed health care that you needed? All of those things, and also asked about housing and food security and those other issues. We find that, where the deficits are, and certainly people report higher delays. The reports of delays in healthcare for last year went through the roof. Through the roof, literally 4 times as much as we saw pre-pandemic. So, with the healthcare system being so strained and all the resources going towards COVID, some other things really got short shrift. And also people maybe weren't able to go get the normal healthcare that they usually got, and put it off until after the pandemic. Probably there's going to be another surge this year with people getting that healthcare and catching back up again.
Well, I also, excuse me, on the agenda, we had have a topic of police community relations. And I think it affects the health of the community in several ways. One of which we've just been talking about is one of the things we want to think about is how can we break off the mental health aspect of what police do? And I think it's one of the things that holds back access to mental health needs is that we send out the police for many kinds of calls that maybe they should either be accompanied by, or maybe instead of them, it should be a mental health professional. I know that if you call the fire department, they do not go out without someone from the EMT side, because they want the firefighters to fight the fire. They want someone else to worry about getting someone to the hospital. And we don't have that model in police. And so that's one effect of the police department on healthy communities. And as well as just a mere fact that there's so much tension, obviously, in some communities between the police and the residents of the community, that also affects the health of the community. So that's the framework of including police community relations in a session on healthy communities.
Well, yeah, certainly, a healthy community is also one that has low crime rates, right? You see that, and where people do feel safe. If you have a community where people don't feel safe walking the streets, that's not a healthy community, in part. So certainly you want people to feel that the police are there to help them and not to necessarily escalate situations. And so in terms of mental health services, it's interesting. Orange County has actually been a great laboratory for this, with all of the cities and their own police departments. Anaheim very successfully implemented what you were talking about, and Huntington Beach as well, I should point out. So Anaheim and Huntington Beach have a social worker that go out by themselves, and Garden Grove just voted to do that as well. In Fullerton and in some other cities, I know they have the model where it's a social worker goes out with a police officer. So both of those models are being tried right now, and we're going to see in terms of how that helps things later. But I think this idea of you don't even need a police officer in most mental health situations, and what research has shown is that when someone is in a mental health crisis, seeing a uniform officer escalates. Rather just the visual, not even anything the officer is doing, but just by being there in uniform and having a weapon,
gun on the side, sure.
Right, can escalate that situation into a violent situation where it might not have been otherwise. So maybe this is why the cities are now trying, only having the police officers basically on call, right? That the person who goes out has a direct line, to be able to call for backup and be able to get a police officer on scene if that's needed. But yeah, those models are being tried. And I do think that's an important aspect of right-sizing police in terms of making sure that they're focused on what they need to be focused on for crime, and taking mental health and also, let's be honest, substance abuse and the kind of crises that can come out of substance abuse issues out of the crime zone and into the social welfare zone.
Correct. Health into the health zone. It's a healthcare issue,
exactly.
not a criminal issue necessarily.
Exactly.
Now, there is an overlap, and sometimes there is criminal behavior involved, but sometimes there's not. We have to kind of have to be able to deal with both.
Well, and having those licensed clinical social workers or whoever is employed to do that, having those people have that direct line for backup is not nothing. I mean, that means that they're part of the police force in terms of they have that direct connection. It's not the same as anybody just calling 911, right? So they do have that backup if it becomes a criminal matter.
Well, what I'd like to do to kind of wrap up this session is first start with the panelists, and maybe start with Mac. If each of you could just take 60 seconds, each of the panelists in turn, to just kind of give an overview of what you would take as the most basic lesson from your perspective, from a public policy point of view. What do we need to do to build healthy communities, maintain them, have our communities thrive? So if each of you could take a minute or so, and then Shana, you could give a little summary, and then I'll close it off by just thanking everyone once again. But Mac, if you don't mind, maybe you'd like to start and just give us a kind of overview of what you think about this whole issue of healthy communities.
Well, I'm this morning I made a list of all the good things that are happening and a list of all the things that I think need attention. My list of good things and my list that needed attention were basically the same. And in building community, I looked around at where I live in this area of Diamond Bar Walnut. And as far as I'm concerned, the health issues with COVID were quite adequate. However, I have a partner who's struggled deeply with the state dental services, which are a joke. The people at Cal Poly and at the Pomona Fairgrounds and the COVID thing were inspirational and dedicated. I've seen great advancement in the traffic issues and some urgent needs and land use issues, but those seem to be beyond the scope of this panel. As far as I can tell, I think we're on top of it. I think a more specific focus that would come down to the level of the street level and make it a bit more comprehensive to what we're trying to do here would help a lot. I got lost in a lot of the dialogue and a lot of the verbosity of knowing exactly what is our focus here and who is the audience we're going for. So I would make those comments to redirect the efforts here so that it's a little bit sharper.
Thank you. Well, I appreciate that. I appreciate that very much. And let me ask Linda, maybe Linda, if you had anything you wanted to add as well. And our focus is always the same, really, is trying to speak to people who are community activists, public officials, candidates to become public officials, to say, healthy communities is an issue. And here's some ideas as how to think about it, talk about those issues from a public policy perspective. And based on this kind of we notice a very superficial touch on these topics, but Linda would like to have you maybe give a little summary of, of what you think about these issues.
What I always see is, and you saw this in COVID, is how fragmented our healthcare system is. There's no coordinated policy or healthcare system. The handoffs from the community to the hospital and all of this is just so completely fragmented. If you have an elderly person that needs inpatient hospitalization, there's very few Jerry psych beds in this whole county, and I presume very, very few in the whole state. Telehealth, I think, is great. Care at home is great. One of the barriers has been that the funding for it, the insurance companies have not at this point said, oh, it's weighted just as much as a hospital visit. An in-person visit. And I think that hopefully they will look at that and change that. I think people are just lost in even how to place their own mother or their father aftercare coming from hospitalization or a skilled nursing facility. I get questions on that all the time. It's just a complete valley. On the positive side, I think CalOptima is using a lot of social determinants in terms of their health risk assessment. When you talked about that, Shana, I think they do not a bad job on that. Many of the determinants you mentioned are all in there. I'm not sure other insurance companies or health plans really do that. So they actually are doing a fairly good job of that. And I think that's really rather positive in that respect.
Well, I appreciate that, but I very much relate to your point about fragmented. I think that is a key theme that comes up time after time. We have a very fragmented system, makes it very difficult to access, and also makes it difficult to evaluate because it's so fragmented. You don't always know what the outcomes are because you have so many different sources and different metrics in each of the sources. So that's a very valuable point, and I appreciate that, Linda.
Thank you.
And Olivia, you had given us some great feedback based on your experience with your members. I wonder if there's any final thought you want to share with us that reflects your members' experience during this COVID crisis or general health, healthy communities in general.
Definitely. There were actually three things that I did want to say specifically to that. One is the importance of assessing our communities and their needs. I think oftentimes we find ourselves, thinking that our communities are very cookie cutter and you can apply all sorts of policies and resources to the same communities, and it doesn't work that way, because even within our smaller communities, I live in Corona, so I'm in Riverside County, you can see the difference between North Corona and South Corona and what they have access to and what the others don't have access to. But again, really assessing our communities down to that smaller level. I think the move to telehealth has been amazing and definitely a game changer for a lot of our clients and our communities. However, what I did want to speak to is access, and now I'm going to be pulling in public education, because not everyone has access to a laptop. Not everyone has access to a phone, right? And so if we're doing that switch, do our communities have the resources to jump onto these meetings, jump onto these appointments, whatever they need? And then lastly, I think definitely we've talked a lot about mental health and the importance of mental health, but I think one thing that we didn't talk about that I think is also very important is even talking about the use of mental health, because it does have a negative stigma attached to it, right? So a lot of folks like, no, I'm stable, I don't need mental health issues, but just, and this is a conversation I have with a lot of friends. I always say, my life changed the moment I started speaking to, a therapist. Just to talk of my life changed completely. And again, moving that negative stigma with even the phrase mental health that comes with it, right? And the education about, hey, mental health doesn't necessarily mean X, Y, Z, or what you think it means. It means, your own sanity, being able to do what you need to do. And nowadays, these resources are very helpful so that we do stay sane, we stay healthy, not so much for us, but the people we work with. But, for me personally, I have 2 little boys, and I know it was very hard with the virtual world. And so I had to make sure that I was also mentally aware of what I was doing and what I needed to keep myself healthy as well.
Well, thank you very much. I appreciate that. And I hope wish you good luck with, have quite a lot of responsibility with so many members and reaching out to the community in so many ways. And it's great to have your perspective. Before we let Shana give a little wrap up from her perspective, Senator, Josh, if you're still with us, I know you're on a very tight schedule, but maybe you could take a minute and just give a little wrap up of your thoughts on this topic.
All right, no, I appreciate it. So thank you for doing this. This has been a terrific conversation and an important conversation. So Linda and Olivia mentioned fragmentation. Shana spoke very eloquently toward the need to streamline. And I would point out something that I think Shana knows well, which is there's a lot of structural issues that need to be solved here. And what strikes me as a member of the legislature in Sacramento is we make policies in a state of 40 million people that includes over 480 cities, 58 counties. In Orange County alone, there's 34 different cities. And so it's not for lack of funds that we're not making progress. Quite often it is exactly the opposite. It's for lack of integration and coordination. And therein lies our imperative. The basis, I think, for a significant progress moving forward. And to Shana's first point, and it remains, I think, the most important, is the first and most important place we should invest is in the public health system, so that every single California has access to the resources they need for both a safe and a healthy community. So Glad to be your public servant and looking forward to continue this conversation as your representative in Sacramento. Thank you.
Thanks a lot, Josh. Shana, you want to just take a minute and see if you can wrap up in 1 minute quickly, and then I'll just say goodbye to everybody.
Oh, this has been such a great discussion. It's so hard to, to pull a whole discipline and years of work into an hour. So I am sorry we weren't able to get to everything, but I think, the one thing I want to go back around to is this idea of health in all policies. That if you are somebody who is thinking about running for office, or you're on your local city council, or you're on your local school board or water board or any of these things, that, hopefully you'll get a chance to read this document and even just look at the pictures, the framework pictures that will really visually make it so that you understand that for every policy you do, and Mac mentioned traffic and said he thought it was outside the scope. It is definitely not outside the scope from my perspective, even if we didn't get to it, because traffic really impacts people's mental health. It also impacts air quality, all of those things.
Even noise quality.
Right. And I mean, I have a background that includes urban planning and public policy and political science, along with public health. And I think all of those things need to be integrated together in thinking about how are we going to build communities from the ground up, and at least knowing when you're in office, the lay of the land, adhering to facts, and using the resources of your community, using the academic resources, using the hospital resources that exist, and trying to really build coalitions together. I'm going to give one quick example from another local legislator, Assemblywoman Sharon Quirk-Silva was promoting in the legislature. She had a bill a few years back that was giving money to help mental health services for homeless people. And I saw her presenting on this bill in front of the committee that was voting on it. I was up there with some of our students visiting that day in Sacramento. And she had with her not only the head of St. Jude Hospital, which is a major local hospital system, but also our Fullerton police chief as well. And both of them speaking about how we need to have mental health services for the homeless to be able to make the whole community better. And that's really the mindset that we need, is this idea of everybody is working towards the same goal of improving the public's health in many different ways.
Well, thank you so much for coming. Thank you for your input and sharing your experience and your professionalism with us. This has been a session on building healthy communities, a part of the Contemporary Policy Institute project with the Bench Project, jointly doing that. You heard a lot of points that are very relevant to public policy. Ideas about the full comprehensive sense of diversity. It's not just a simple idea of diversity. It's income diversity, it's gender diversity, it's language diversity, it's every kind of diversity. And we have to approach any problem with a full understanding of the full diversity of our communities. We've heard about bringing the marginalized communities in. We've heard about how fragmented some of our systems are, how bureaucratic they are, how difficult they are to access. So it's an awful lot of public policy implications in this discussion. And we hope everybody enjoyed it. We hope it leads to further action. We want to also point out to you, if you have further feedback, please send it in to us. It should be on the screen now. You can send it to cpifound.org. Give us your feedback. And if necessary, we're prepared to do another session based on the feedback that we get. It might be a good idea to do a follow-up session in the future. But to say thank you one more time, thank you to all of our panelists. Thank you for your time and your input. Thank you, Shana, once again.
Thank you.
Hope to see you
Glad
again
to be
soon.
here.
Thank you very much.